Howdy. It's May 3rd, 2009, and another Persiflager's Puscast. Review the infectious disease literature with snarky commentary for the last 2 weeks of April 2009. Remember, if you're sick of this intro, skip ahead to the next chapter, but that requires using an enhanced podcast. This is on iTunes, so feed my ravenous ego and write me a good review on iTunes. Time for the usual required boilerplate. This is brought to you by Pusware LLC, publisher of the Persiflager's Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion. Your uber hyperlinked electronic guide to infectious diseases at pusware.com. All the opinions, those of Mark Crislip and Pusware LLC, and nobody else who knows a burro from a burro. This is CME accredited. Listen and take the online quiz and get a free half an hour of CME. Thank you, Legacy Health Systems. Because this is CME accredited, I must mention my conflicts of interests. I don't have any. Remember, operating under the assumption that the world needs more Mark Crislip, you can get more of me on my Quackcast, available on iTunes. You can read my quack-related writings at sciencebasedmedicine.org and my occasional infectious disease blog, Rubor, Dolor, Kalor, Tumor, found on the Pusware site. Bandwidth, of course, ain't free, so feel free to donate or purchase the compendium and keep this going. I saw where the ACP was giving an hour and a half's worth of audio MP3 CME, and they charged $50 for it. This is a deal in comparison. And now, on to the literature. Two things. For the enhanced podcasts, you will occasionally see graphs, etc., from the literature in the window. So if you're looking at this on your iTouch or listening to it on iTunes, you can actually see some of the literature that I'm talking about. It depends on whether or not the given article has an applicable graph or other visual to display. Issue 2 is you probably want me to talk about swine flu, and I'm sorry, I ain't going to do it here. If you'd really like to hear me yammer away about swine flu, you can listen to The Skeptic's Guide to the Universe that's published this Saturday, also available on iTunes, where I am interviewed and yammer on about swine flu. It's episode number 197. And hopefully Steve Novella does his usual psychic magic and cuts out all the idiotic things I say, which is most of the interview. And don't forget the science-based medicine lecture that precedes TAM. I'll be there in July. I'll be talking on Lyme disease. And I do like a twist of lime in my Cosmopolitan, so come on by and buy me one. The world is a vampire. No, wait, that's Smashing Pumpkins. The world is a dirty place. That's Mark Crislip. We've talked about neckties, stethoscopes, beepers, cell phones, and rings as a source of infection in the hospital. This study looked at portable X-ray equipment of all things, and in this particular study, they found that 1% of people who were taking portable X-rays were found to practice good infection control procedures. But what was really appalling is that when they cultured the surfaces of the portable X-ray machines, they found gram-negative bacilli, sometimes resistant ones, in 40 to 50% of the samples. So a unexpected finding in my mind is that a source of infection in your ICU might be your portable X-ray machine or the text therein. You might want to consider autoclaving both of them. But if you are having a problem with transmission in your ICU, think of the portable X-ray machine. Everybody knows that HIV causes ITP, idiopathic thrombocytopenic purpura, because the HIV proteins bind to the platelets and cause them to be destroyed. But is it associated with TTP, thrombotic thrombocytopenic purpura? Probably, but not as much as one would like. The series out of Clinical Infectious Diseases looked to see how often HIV was associated with TTP, and the answer is it is, but not that commonly. More likely, the TTP is actually due to some other underlying opportunistic infection that is manifesting like TTP. The bottom line is you have a patient with HIV who also has TTP. You need to look very carefully for diseases like CMV and malignancies that can mimic TTP. And hey, would you looky there in the Enhanced Podcast? There's a table of things to think about. So you have an HIV patient. When do you start HAART? Well, we talked about this last week in a Lancet article, and yet another article in the New England Journal of Medicine suggests that the sooner you start it, the better. They first looked at 8,300 patients, a quarter of whom received therapy with their CD4 counts between 351 and 500, and 75% of whom had deferred therapy. Those that had deferred therapy had an increased risk in death of 69%. Then they went on and compared 9,100 patients, a quarter of whom initiated therapy when their CD4 counts were above 500, and three-quarters of whom had deferred therapy. In the deferred therapy group, there was an increased risk of death of 94%. So it would appear that you want to start your antiretrovirals in an AIDS patient when their CD4 counts are above 500. The sooner, the better. And now there are two studies that suggest this, the Lancet article and the New England Journal article. Although the official guidelines recommend lower CD4 counts, and a patient who has CD4s greater than 500, based on this New England Journal of Medicine article, they should get antiretroviral started when their CD4 counts are above 500. I think that's eminently reasonable myself. Fortunately, for historical reasons, I don't treat hepatitis C. It has gone to the gastroenterologists. I will let you know that there's a new protease inhibitor that interferes with the hepatitis C serine protease called telaprevir, which is not from the tilapia fish, as best I can determine. But when used in combination with pegylated interferon alpha and ribavirin with genotype 1 hepatitis C, it markedly increases the sustained virologic response from 46% without telaprevir to about 60% with. The rate-limiting step of this medication seems to be severe rashes at about 8 weeks, as well as pruritus and anemia. So this looks to be a nice addition to the armamentarium for the treatment of hepatitis C. I'm sure they'll come up with less toxic equivalents in the not-too-distant future. Also, the Annals article this month looked at what to do with patients who failed their ribavirin plus pegaferon alpha-2A. They retreated these patients with ribavirin and peginterferon alpha-2B, or not 2B, that is the question, for either 48 weeks or 72 weeks. Can you imagine being on interferon for 72 weeks? But if they did that, they eventually got a response rate. In the 48-week group, they got 8% to be permanently suppressed, and in the 72-week group, they got 16% to respond. So it ain't the greatest on the planet, but if you have someone with chronic hepatitis C who doesn't respond to the first short course, you can go 72 weeks with interferon alpha-2B plus ribavirin and get a 16% chance of sustained suppression. The world of vancomycin resistance is nothing but subtle. You have vancomycin resistance where the MIC is greater than or equal to 2, but you can also have heteroresistant MRSA. Heteroresistance are organisms that overall are susceptible to vancomycin with MICs less than 2, but they have daughter populations that have slightly higher MICs in the 1 to 2 range. So some of the daughter cells are susceptible and some aren't, and these are called heteroresistant staph. Heteroresistant staphs cannot get married in most states of the Union currently. The question is it important? And there are 2 studies out that address this issue of heteroresistant MRSA. And they show that when compared to susceptible strains, them what have heteroresistant MRSA are more likely to have a longer period of prior use of vancomycin or to have a deep refractory infection like bone and joint or a prosthetic joint infection. They are also more likely to have longer episodes of bacteremia and to have longer culture positivity. So heteroresistance of MRSA is a bad clinical thing, although in two studies, there was no difference in mortality in patients who had regularly susceptible MRSA and the heteroresistant MRSA. If, however, your MIC is greater than or equal to 2 for your Staph aureus, you should change antibiotics, as mortality rates do increase when you get MICs greater than 2. And when I have serious deep infections like prosthetic joints or bone or endocarditis and my MICs are 1, I get nervous, although I'll be damned if I know what I should treat them with, since all of our current MRSA agents equally stink on ice. I will mention here just in passing that in the guinea pig model of prosthetic infection, let's say you have a guinea pig who breaks its hip and you put in a little tiny artificial hip, that daptomycin at 6 mg per kg plus rifampin was better at eradicating the staph in a guinea pig model. So maybe there might be a use of rifampin plus daptomycin in refractory MRSA infections, though it's my understanding that daptomycin ruins the flavor of roast guinea pig, a delicacy in the Andes, evidently. And as long as we're on the topic of Staph aureus, you remember? Yes, remember, back in the day, when we talked about how acute pneumococcal pneumonia increased your risk of myocardial infarction, well, it happens with Staph aureus bacteremia as well. Yes, it does. The study, which is out of the Scandinavian Journal of Infectious Diseases, looked at 588 patients and found that if you had Staph aureus bacteremia, your risk for a myocardial infarction in the subsequent 2 days went up 35-fold. Which is far more than you can sequentially fold a piece of paper in half, which I believe is limited to a maximum of 8 times. Try it, see if I'm not right. That's folding paper, not getting staph bacteremia. I had several nice emails to let me know that Eikenella corrodens smells like bleach. So, bleach it is. Now, this study looked at someone who was chewing on betel, B-E-T-E-L. Betel is a plant found in Malaysia and Indonesia that's used as a stimulant as well as an antibiotic in the treatment of musculoskeletal pains. It is evidently, according to the Wikipedia, a topical cure for constipation, which I find a little odd. But it's also not good for your teeth, evidently. And this gentleman was a habitual chewer of betel. He had rotten teeth and presented with back pain, and he found that they had Eikenella corrodens discitis and osteomyelitis that they blamed on the rotten dentition due to habitual betel chewing. So, don't chew on betel without maintaining good oral hygiene. And if you smell bleach, it's either Eikenella corrodens or an early Nirvana album. The later ones, of course, smelled like Teen Spirit. I often say that the 2 most efficient ways to spread infection are cough and sex. And if you cough while having sex, you're probably dead. But perhaps I'm wrong there, and it's food that's the problem. And here are 4 outbreaks with different foods, so bon appetit. The first was an outbreak of Shiga toxin-producing E. coli that was associated with organic beef sausage. Beef sausage. The next was a multi-state outbreak of salmonella associated with unpasteurized orange juice. This is not the first time there have been outbreaks associated with unpasteurized fruit juices. Please, drink your pasteurized juices. There's an outbreak of salmonella as well with alfalfa sprouts. And finally, an outbreak of E. coli OH157 that swept through Wisconsin that was associated with spinach. This is why I only eat fried foods. At least the cardiologists can stint me, but with resistance on the rise, if I eat something that's infected, I'm toast. Bon appetit! And then, if you're going to go to your chicken, just remember that according to a study in Scotland where they looked at the genotypes of the Campylobacter, they found using molecular typing that 76% of the Campylobacter infections in Scotland was associated with chicken as the source. Let us move from the diarrhea to the diabetic foot. This study looked at the difference in the microbiology between diabetic foot ulcers that were due to ischemia versus those that were due to neuropathy. And although there were a piddly number of patients, 21 in the ischemic foot ulcer and 29 in the neuropathic foot ulcer, they found staph epidermidis much more frequently in those that had ischemic diabetic foot ulcers than compared to neuropathic foot ulcers. Again, with a total of 50 patients, the results are questionable. But given the difference in pathophysiology between neuropathy and ischemia, you may find a difference in the microbiology of the foot. This needs to be replicated in larger numbers of patients, as is always the case in every study ever done by anybody ever. Perhaps I'm wrong, but I think infectious diseases has more studies with small numbers of patients that make it difficult to really know what to do compared to any other subspecialty. Yet, when you're starting an area of clinical research, the initial studies are always small. This study looked at the results of septic complications in patients in an ICU in Japan. They were randomized to either get some symbiotics, i.e. Bifidobacterium or lactobacillus and some galacto-oligosaccharides, or they had just observation without symbiotics. There are 29 in the treated group, 26 in the untreated group. Patients who had the symbiotics had fewer episodes of enteritis, pneumonia, and bacteremia when compared to those that didn't. Now, the numbers are small. It was not placebo-controlled. And yet, I'm increasingly convinced of the benefit of probiotics in patients in a variety of situations. It's probably best to prevent antibiotic-associated diarrhea in the hospital. Other indications are not as clear-cut, but not allowing pathogenic bacteria to overgrow in the guts of sick patients does at least have some biologic plausibility. So we'll see. For now, I am less hesitant to be a grumpy old man about the use of probiotics in my hospital. I still think if you're going to give these to patients, they should be in the form of yogurt and not in the form of pills, given that some studies have shown the pills to be sterile and other studies have shown the pills not to contain what the label says. However, a good complicated yogurt with a microbiology of poo may be of benefit. Obesity, it turns out, is a risk factor for both UTI and pyelonephritis in men or women. Obese patients are 2.5 times higher risk of a UTI and 5 times higher risk for pyelonephritis. And as the BMI goes up, so does the risk for both. For example, if your BMI was less than 30, the prevalence of UTI was 12%. If your BMI was between 30 and 35, your risk was 14.25%. And if your BMI was greater than 50, which I cannot imagine, your prevalence of UTI was 17.6%. As I give this podcast here in the beautiful Pacific Northwest, it ain't so beautiful. We're having thunder showers and it's rainy and humid, which, as I've talked about in the past, is Legionella weather. Maybe we'll see an increase in Legionella in about 10 days. But there are other risk factors for Legionella, including potting soils. There have been outbreaks associated with potting soils and Legionella in the past. This study looked at the ability to isolate Legionella from potting soils. They were able, in Switzerland, to detect Legionella species in 45.7% of potting soil samples by culture. And by using PCR techniques, they found CFUs between 1,000 and 10,000 per gram of potting soil. So don't aerosolize your potting soil. The ongoing debate, when and with what do you treat neutropenics with antifungal? This study randomized patients to get either empirical therapy for fungi, which is anybody who had persistent or recurrent fever was treated with an antifungal, or what they called preemptive therapy, which is patients who had clinical, imaging, or galactomannan assay evidence which suggested they had an infectious disease that was of the mold variety. They treated them with ampho, depending on renal function. It was lipid ampho. And they looked to see how patients did in terms of survival and the development of fungal infections. They found that preemptive therapy, i.e., waiting until they had some clinical evidence of a potential invasive mold, was associated with an increased incidence of invasive fungal disease, but did not increase mortality and did decrease the cost. However, when it comes to mortality outcomes, there was a slight but non-statistically significant difference in favor of the empirical therapy. 97.3% of those in the empiric treatment survive versus 95.1% in the preemptive therapy. That's a 2% difference in a total number of 293 patients. I am personally inclined, based on other data, to have everybody on empiric antifungals and use one of the imidazoles like voriconazole or preferably posaconazole. But this is one of these ongoing areas that will never be clarified in a definitive clinical trial because the nature of the molds keep changing, the nature of the medications keep changing, and the nature of the neutropenia keeps changing. And speaking of funguses, those of you living in Tennessee are probably aware that blastomycosis is increasing in incidence as people start living increasingly in rural Tennessee. They comment now that the treatment of choice for this particular endemic fungus is itraconazole. So I know what you're saying to yourself. You're saying, oh, I don't want to go to rural Tennessee. I think I'll go on vacation to the Cambodian-Thai border. It's warm. They got cheap food. Bad idea. There's now a new strain of resistant malaria there. The organism has now become resistant to artemisinin. So, did I pronounce that right? I don't know. Artemisinin. Artemisinin, I guess. Anyway, it's becoming resistant to that particular agent. It seems that Southeast Asia continues to be the epicenter of malarial resistance. So whenever we have new agents, we turn them loose into Southeast Asia, we get success for a while, and then the organism is resistant. Resistance is inevitable, as the Borg said. I'm sure you're all actively involved with your institution's SSI bundle, surgical wound infection bundle. That includes appropriate antibiotics, removal of hair by clipping and not shaving, tight sugar control during the perioperative time, and making sure patients are normothermic as soon as possible after they get out of the OR. The other thing which has been shown in a recent meta-analysis is that you can decrease your infection rates by about 3% just by keeping the patients on supplemental oxygen in the postoperative time. So that's 5 things you can do to help decrease infections in your hospital. And the better you are at hitting your mark on those procedures, the lower your infection rates will be. The heck, that's it. There's a bunch of reviews out this month. There's the New England Journal has one on aspergillus. There is a consensus guidelines on the treatment of influenza. The GYN folks have released their recommendations for perioperative surgical antibiotic prophylaxis, but that stuff is not the meat of this particular podcast, so I'm going to bring it to a close. So that's it, the end of the April 15th through 30th podcast of the Persiflager's Puscast, review the infectious disease literature. Now that you listen to this, take the CME accredited quiz and get a half an hour of free CME thanks to Legacy Health Systems. Brought to you as always by Pusware LLC, the publisher of the Persiflager's Annotated Compendium of Infectious Facts, Dogma, and Opinion, your uber hyperlinked electronic guide to infectious diseases at pusware.com. Don't forget, the world needs more Mark Crislip, so there's my Quackcast, there's my science-based medicine blog, there's the Rubor Dolor Kalor Tumor blog. Bandwidth ain't free, so feel free to purchase the compendium and support this podcast. Remember, CME is expensive. I'm cheap, and I'm easy. This is copyright 2009 Creative Commons license. The music is by my son when he was 12 years old, improvising on the guitar. And as always, thank you for allowing me to participate in this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation. Goodbye.